So I will now introduce our first speaker, Dr. Armin Aprikian. He's a really good-looking guy. He's done a few things in urology. Come on up. No, I'm just kidding. I'm just kidding. Dr. Aprikian happens to be one of the most humble individuals that I've ever met, aside from his brilliance. I've been honored to work with him for a great number of years. And just to give you an idea of how humble he is, I sent an email to him and to his assistant to get his bio. He sent about one line saying exactly what he does and what his interests are. Luckily, I'm using the bio I received from his assistant. So Dr. Armin Aprikian graduated from the University of Sherbrooke Medical School in Quebec in 1985 and completed his urology residency training at McGill University in 1990. He then pursued a 3-year research and clinical fellowship in urologic oncology at Memorial Sloan Kettering Cancer Center in New York City. In 1993, he was appointed assistant professor of surgery at McGill University and began his career in prostate and bladder cancer research and as a clinical urologic oncologist. In 1998, he became the McGill Division of Urology Training Program Director, and in 2000 established the annual Canadian Senior Resident Urologic Oncology course, which runs to this day. In 2004, he became the head of the Division of Urology at McGill University and the Chief of Urology at the McGill University Health Center. In 2007, he became full professor of surgery, and in 2009, he was appointed medical director of the MUHC Cancer Care Mission and Department of Oncology. He has been awarded the American Society of Clinical Oncology Young Investigator Award. Imagine, he skipped all of this in the email he sent me. The American Urologic Association Practicing Urologist Award, the Canadian Urology Association Scholarship, the McGill University William Dawson Scholar Career Award, and the Quebec FRSQ Clinical Scientist Award. He has obtained independent grants from several organizations, including the U.S. Department of Defense and the National Cancer Institute, and has served as editor-in-chief of the Canadian Urology Association Journal. He serves on several boards of directors, including Procure, I'm happy to say, the Cedar Cancer Institute, Goodman Cancer Research Center, MUHC Research Institute, and BioNiche Life Sciences. He's actively involved in a leadership role in provincial guidelines in bladder cancer surgery outcomes and is the scientific chair, or was the scientific chair, of the Canadian Urology Association annual meeting of 2011. He has published over 100 papers, and his most recent achievement was the appointment as the McGill University Richard Tomlinson Professor in Prostate Cancer in 2010. Dr. Aprikian.
Thank you, Malvina, for those kind words. I have to speak to my assistant to make sure that she listens to me and not to you. Thank you all for coming this evening. I noticed that many of you are patients that I see in my office, and that can mean one of two things. Either you really like to see me often, or that when you're with me, I don't give you enough time, and you're here today to catch up and to ask me questions. I hope it's the first. I thought that over the next 30 to 45 minutes, we would discuss what are some of the new developments in prostate cancer treatment. Prostate cancer treatments have changed a lot over the last few years. There's a lot of new things that have come forward, a lot of new research, and new things that have challenged what we used to do many years ago. So I thought it was an opportune time to review some of the highlights. So what you're going to hear are some highlights, new things that hopefully you can use as opposed to a complete lecture on the prostate and prostate cancer. So what do I do? Just press this. Okay. Thank you. So there are essentially several key messages. And if you take away these key messages, I think the point of the presentation, most of them are here. And if we can just have these slides show on this monitor, there's no way? Then I have to turn my head. Okay, well, the key messages are relatively straightforward, but I think each one is based on a lot of research that has been published in the last few years. The first one is that screening for prostate cancer with a blood test can reduce death from prostate cancer, but at a significant cost. And you've heard in the newspaper, seen in the newspapers, heard on the television or on the radio, there's been a lot of questioning of whether the PSA test is a good test or not. I'm here to tell you that the PSA test is a very good test. It's not a perfect test, but it reduces death from prostate cancer, which is new information over the last 2 years. Second, it's possible that many of you are taking multivitamins to prevent prostate cancer or for other illnesses. Well, unfortunately, in the area of prostate cancer, vitamins do not reduce the risk of prostate cancer. This is new information, and may be harmful in some cases. The notion that vitamins really don't cause any harm, we're realizing more and more that if you take too many of them, there's a problem. Drugs that decrease the size of their prostate, BPH, which is swelling of the prostate that men suffer as they get older, drugs like finasteride and dutasteride that affect prostate size, they can also reduce the risk of prostate cancer. So I think that's an important element when we talk about how to deal with this illness in the realm of prevention. There is some risk with that, and I'm going to cover that for you. Hormonal therapy, which is the mainstay of advanced prostate cancer, has been around for many, many decades. We've learned recently that you don't need to give hormone therapy on a continuous basis to everyone. That in some cases, it's actually not a bad idea to stop, start, stop, and start. Chemotherapy for prostate cancer has been shown to be much more effective than previously thought. We can now extend life for patients who are failing hormonal therapy with the use of chemotherapy. We have new treatments that are recently made available that in the setting when we felt chemotherapy was the last resort, it's no longer true. We can now fall back on other treatments that can prolong life even longer. New drugs such as Abiraterone that is currently approved, and another form of chemotherapy, cabazitaxel. The other element that's very important is bone health. We know that as men get older, their bones get weaker, but if you add hormone treatment to that, the bones in men age quicker, and therefore it's very important to lead a healthy lifestyle, take calcium, vitamin D, and maintain your bone health. We also know now that there's a new drug out there, currently available in the last year, called denosumab, which can enhance or help prevent bone loss that occurs with prostate cancer treatment. So the final message is, in fact, men with prostate cancer are living longer, even if they have advanced cancer. And finally, research is the reason why we get all of these developments. Without research, none of these findings would be available today. So let's review some of the items that support each of those key messages. First, just for those who are not aware, but the prostate is this little organ right here. It's not a big organ, but it causes a lot of trouble. In fact, if you count BPH, which happens to just about every man, prostate cancer, which is a very common cancer, 1 in 7 men, and prostatitis, which is an inflammation of the prostate gland that tends to happen in men as they're getting older, you lump all those three together, it's the organ that causes the most trouble in men. And of course, understanding where the prostate is situated, you can see it's between the bladder and the urethra, and here's the rectum. So treatments that are aimed at the prostate, whether it's surgery or radiation, will affect some form of quality of life, whether it be with bowel function, urinary function, and sexual function. So first key message, the PSA test is not a bad test, even though we've been hearing this a lot in the recent literature in the news. Here's, for example, some clippings or cutouts from websites a couple of years ago when some of the results of studies looking at PSA screening were published. And most of them, as soon as the studies came out, claimed that this test should no longer be done. PSA testing actually causes more harm than more good. And there was a lot of questioning that are we doing the right thing by having men get tested? This created a lot of stir in the community, especially people who are out there coming to the offices, getting checked. People were asking questions, should I have a PSA test? Well, I think they got it wrong. And nowadays, in the last, in this year, 2012, there's a lot of pushback on this message that analyses of these studies actually show PSA testing is helpful. The PSA test is a blood test. And essentially what it does, it measures a protein called prostate-specific antigen. This is a protein that's found in high quantities in semen. It's really meant to help with fertility, to have children. But sometimes when the prostate gland is sick, that protein leaks into the bloodstream. And when the prostate is very sick, like infection or cancer, the amount of leakage increases, and therefore the blood test, the PSA count rises. That's how we use it to detect prostate cancer. However, the PSA count can be high for a lot of reasons, not just cancer, and that's why people say it's not such a great test, and I agree. However, it's the best test we have, and we now know that if we do this test, if it's used properly, it saves lives. So in 2009, in the New England Journal of Medicine, it's about the most prestigious medical journal you can find, 2 papers were published, both trying to answer the same question. If you have a PSA test regularly and get checked for prostate cancer, do you save lives? One study was done in Europe, the other one was done in North America. Both studies, unfortunately, concluded the opposite finding. The study that was done in North America concluded that PSA testing did not decrease death from prostate cancer. The study done in Europe showed a big difference in that men who were screened had less risk of dying of prostate cancer than those who were not screened. And there are many reasons for this difference. The main reason for the difference is that the North American study, everyone has agreed today that the North American study was not really done properly. To do a proper study of screening, you have to tell some men, don't go get checked. Please don't be checked, because we need to see if those that do get checked do better than you. Well, if I told you that, what's the first thing you're going to do? You're going to go get checked. So in the North American study, where some men were told don't get checked, half of them actually got checked. And therefore, it wasn't a proper study. In Europe, they listened. When they were told don't get checked, they didn't get checked. And in that study, we now learned that if you do the PSA test properly, death from prostate cancer is decreased by 29%, not 5%, not 6% like we see with mammograms for breast cancer. We're seeing 29% reduction in prostate cancer death. However, no impact on overall mortality. What does that mean? That means if you take 100 men in one group, 100 men in another group, one group you do a PSA testing, the other group you don't test, the group that got tested, less men, 29% less, die of prostate cancer. But if you look to see, did the men in general live longer? The answer is no. Both groups still lived the same amount of time. So instead of dying of prostate cancer, maybe they died of something else. So some people use that argument to question the validity of the PSA test, since you're not prolonging life. I think it's the opposite. If as a prostate cancer specialist, I can avoid prostate cancer death, and if then it's up to other doctors and medicine and the patient to make sure they don't die of cardiac illnesses or diabetes and so forth. And each illness can be corrected. Now, there were some negatives of the study. In order to save one life, you had to screen 1,000 men. So that's a lot. So some people say, well, wait a minute, that's very expensive. It's true. There's a cost to this. But we cannot say that because it's too expensive, it's not worth saving that one life. The number of men needed to be treated to save one life was 37. That means 37 men had to go through either surgery or radiation treatment so that one could survive. So that seems like a lot. But if you compare this to some other things like cholesterol drugs or cardiac surgery or breast cancer surgery, these numbers are actually quite favorable. Now, what looks a bit better is the number of men needed to be treated to prevent one from developing metastases. We know that metastases development is the first step, unfortunately, towards a cancer death, and that is 1 in 27. So the test does save lives, but there are some side effects and risks associated. So it becomes a balance. So my personal view on this is we shouldn't stop screening. We shouldn't tell people don't get checked. That's like putting your head in the sand. We have a test that can save lives, but I don't think we need to treat everyone. The reason why it takes to save one life, you have to treat 37, is because a lot of the men in which we find some cancer are small, low-grade, what we call insignificant cancer, and therefore it's better you don't treat them. So if we were a bit more rational and selected men who should be treated and who shouldn't, I think that ratio of men number needed to treat would be much better. And of course, if we can find a way to prevent the cancer, that'll be even better. Then we don't have to go through all of the side effects and so forth. And of course, we need to ensure that the treatments we do cause less and less morbidity, less and less side effects. The reason why men don't like prostate cancer treatment is because it can affect sexuality, urinary function, bowel function. If we can improve on how we deliver the treatments, it becomes less of a problem. Okay, second key message. Vitamins do not reduce the risk of prostate cancer. How many here take vitamins for prostate health? No one. I'm very surprised. How many here take vitamins? Okay, great. And all of you take it because you want to prevent heart trouble, you want to keep your bones healthy, but not for the prostate, right? Excellent. Good. In my practice, I can tell you many patients ask me, Dr. Aparikian, I found this prostate health over-the-counter substance at a natural, can I take it? What do you think? And my answer is always the same. I don't know what's in that. I doubt that it's going to hurt you. If it makes you feel better, go ahead. But please allow me to keep checking you to make sure that whatever you're doing is not masking my ability to take care of you. Now, up until recently, it was felt that the same thing could be said about vitamin E and selenium. Many of you are taking vitamin E. Well, for years, this is what we thought, that vitamin E and selenium actually can prevent prostate cancer. Well, there was a very, very large study conducted in the United States, one of the largest of its kinds, testing multivitamins, vitamin E and selenium, and checking to see, can we prevent prostate cancer by taking these drugs? It was a study called SELECT. Our hospital, as well as many others, were part of this. And the study was quite simple. There was over 35,000 men over the age of 55, broken down into 4 groups. One group took vitamin E, one group took selenium, one group took both, and one group took neither. They were given placebo. They were blinded. No one knew what they were taking until the end of the study. And the study results showed, disappointingly, no difference, no decrease in prostate cancer rates, whether you took the vitamins or not. However, what was a surprise was there was slightly more prostate cancers in the men who were taking vitamin E. This was totally unexpected, yet a real result. In the group taking selenium, there was a little bit more type 2 diabetes. So this, I think, dampens a bit the issue of using or taking multivitamins to prevent something. Second message is if you take too much of it, you may be actually creating some harm. No one knows the exact amounts that can be taken, but in that study, if I go back, précédent, these were the amounts taken. Okay, these are not very high amounts. In the vitamin E literature, if you take 1,000 milligrams of vitamin E or more, you can start having cardiac trouble. So if you're taking vitamin E, please don't pass the 400 mark. Next message, drugs that decrease the size of the prostate, such as Proscar or Avodart, these are drugs that men take for BPH, can reduce prostate cancer risk. So these drugs do essentially the same thing. They block the conversion of testosterone, which is the male hormone, to a metabolite, which is the active compound, which promotes the prostate health, the growth of the prostate. So if you block this conversion, you have less of this, and the prostate shrinks a little bit. It doesn't disappear, but it shrinks. And by shrinking, men urinate better. And that's why these drugs are approved to be used for benign prostatic hyperplasia. So the question was, well, if it can make the prostate smaller, maybe it could also prevent cancer development in the prostate. Very logical question, and this was tested. So this was published in 2003, and then dutasteride, which is the other drug, a newer drug called Avodart, was published in 2010, both essentially asking the same question, both essentially showing the same thing. Both drugs, 2 separate studies, slightly different patient population, showed the same thing. These drugs can reduce the risk of finding prostate cancer on a biopsy by 25%. Again, not a small reduction, a big reduction. However, the reduction is primarily in the low-grade disease. Remember earlier I said if you use the PSA test too much, you end up finding small, low-grade, probably insignificant cancers, cancers we didn't want to find. These drugs seem to be decreasing that type of cancer, the cancers that we don't want to find. So I think the two go well together. The other thing that's interesting is that the PSA test, which everyone is poo-pooing, performs much better if you're taking one of these drugs. The variability of the blood test in your blood is much more decreased. So someone who's taking Proscar or Avodart and who's being checked with a PSA test, the power of the PSA test is improved. It makes it perform better. Now, like everything in science, for a lot of good, there's always sometimes a little bit of bad. And here, there is a slight increase, if you're taking these drugs, that if you do get cancer, you get the bad kind. So the question is a 25% reduction worth the 1% increase in the bad kind? So it becomes a judgment. And some organizations have warned against the use of these drugs. Personally, I think that if you're a man who has a big prostate and you are suffering urinary symptoms, these drugs can help relieve those symptoms and at the same time reduce unnecessary prostate cancer. If you're a man who has a strong family history, you've got 2 brothers or your father died of prostate cancer, and you have an elevated PSA test, you've been biopsied and it's negative, so therefore you're still at risk, one approach is to take one of these drugs, but we're not yet at the point where we can recommend that all men should be taking these drugs. Next message. Hormone therapy does not need to be given continuously. In many cases, intermittent therapy is just as effective with better quality of life. So for men in this room who are on hormone therapy, you know what I'm talking about. You know what some of the side effects are from hormone therapy. So this was questioned in a study. What happens if we stop treatment, start, stop, start in a cycle? Are we harming patients? So this was done in a study which was mainly a Canadian study. Patients were given hormone therapy for 8 months, and then it was stopped. And then it was restarted when the PSA count passed 10. The study had to be stopped early because people quickly realized that the cancer was being controlled just as well in both groups, yet the group that had the stop and start were feeling much better. The men were feeling better. So, and that's because the quality of life of men was better in the intermittent therapy arm. So, I think this is relatively new. Again, this is something you could ask your urologist or your doctor to say, and if you're on hormone therapy, is it absolutely necessary that you stay on the hormone therapy? In some cases, it absolutely is. It should not be stopped. But in many cases, if you're not happy with the side effects, it could be stopped, and you may feel better, and it could always be restarted. So that's a new concept which I think is very beneficial. If we move on to more advanced prostate cancer and talk about chemotherapy, there's a drug called Taxotere, which is otherwise known as docetaxel. This drug has been proven to prolong life in the setting of very advanced cancer. This is for patients whose cancer has advanced despite hormone therapy. And for many years, we felt that there was not much that could be done for men whose cancer was progressing after hormone therapy. Yet this one drug, given intravenously every 3 weeks, has shown to improve life by several months, and in some cases, a couple of years, which is remarkable in the setting of advanced prostate cancer. And if that patient is suffering from pain, the treatment actually relieves the pain. It's very well tolerated. Yes, men lose their hair, but that's about the worst side effect. And it's so well tolerated that even in very elderly men, they could tolerate such treatment. Usually chemotherapy is not given to very elderly men because of the side effect profile. This drug can be delivered. It's often delivered on an average 6 to 10 treatments. It's coupled with a drug called prednisone, which is like cortisone. And what's nice is that it can be re-administered. After 6, 7 treatments, everything went okay, you can stop. And if 6 months or a year later the disease is waking up, you can give it again. So that's a very important development in prostate cancer chemotherapy. Here's one example of such a patient. This is the patient's PSA level. This is a logarithmic scale, so this is the patient's PSA is not 10, it's probably around 30, drops down, then the treatment is stopped, PSA goes up, treatment starts again, goes down, treatment is stopped, PSA goes up, and this cycle in this particular gentleman, as you can see, 0 to over 1,000 days, we're talking about 3 years of life in someone who has very advanced prostate cancer. So this is actually very promising. Now, sometimes up until a couple of years ago, we felt, well, after this chemotherapy, well, then that's really it. There's not much more we can do. Well, surprise, that's not true. There are new drugs available today for this setting. There are new treatments recently made available, one called Abiraterone, the other one called cabazitaxel. These can continue to prolong life even after initial chemotherapy. So when we thought a few years ago that after hormone therapy, there's not much more we can do, we now have 2, maybe 3 rounds of chemotherapeutic drugs. Each can provide prolonged life. So Abiraterone, otherwise known as Zytiga, is a product that was studied in patients who had already failed chemotherapy. And this study showed that there's a 35% reduction in the risk of death in men who already had the chemotherapy, the Taxotere. So these patients who had unfortunately failed conventional chemotherapy were now put on a study, and there is a 35% reduction in risk of death and a 36% increase in survival. These are actually quite remarkable findings in men who have advanced prostate cancer. Now, this is the same, this is the drug called Zytiga. This is now available. What's nice about this compound is it's available, it can be taken orally. Traditional chemotherapy is given intravenously. This drug is available for oral consumption, which makes it much more convenient for the patient. It must be given with prednisone. And again, these are the study results. There are some side effects, such as a little bit of high blood pressure, some fluid retention, maybe a little bit of loss of potassium, but all of these are very easily manageable. So this is actually, and this was just made available last year. So this, I think, is a major advance for men who have advanced prostate cancer. Recently, what we learned in the news, and the results of that part of the study will be shown slowly, but in the soon, is that this particular drug can even be given before chemotherapy. It's not indicated for that at the moment, but this is where we're heading. So that it's possible that in the future, when men are failing hormonal therapy, before going to chemotherapy, this may be a drug that patients may opt for. The other drug that is shown to have benefit after initial chemotherapy is cabazitaxel. Again, this is an intravenous form of chemotherapy, similar to Taxotere, but has shown improvement, can improve survival in men who've already had a lot of chemotherapy. So now, as I said, you have 2 options in the face of a patient whose cancer has progressed after chemotherapy. Again, several months of improved survival. Now, while we're treating the cancer, we have to make sure that we're taking care of all of the elements of the patient. And this means things like bone health. We know that prostate cancer treatment and prostate cancer itself can affect the bones. One of the most common sites for metastases from prostate cancer is the bone. And hormone treatment that we use for prostate cancer can make the bone brittle. One of the main reasons why women become osteoporotic is because of after menopause. The hormone levels go down, the bones weaken. In men, when we give hormone treatment, essentially we're creating menopause. Hormone levels like testosterone go down, and then the bone becomes weaker. So it's very important that we keep an eye on this. So what is osteoporosis? We tend not to think about osteoporosis in men. It's very, very common, very, very important and discussed for women. But in men, we don't discuss this very much, but it does exist, especially in men who have prostate cancer. So this is the systemic skeletal disease characterized by low bone mass. And hormonal cancer treatments can create osteoporosis in men. This is just a little graph showing you that the longer a man is on an LH-RH agonist or on hormonal therapy, the more the bones get weaker. And when bones get weaker, what can happen is you can have a fracture. A simple fall can create a fracture. So how do we address this? It's very important that men on hormone therapy are supplementing their diet with calcium and vitamin D. This must be done. We have to adopt healthy lifestyles. If you're smoking, that's bad for your bones. You have to stop smoking. If you're drinking too much alcohol, you need to decrease alcohol intake. Very important to exercise. Walking is excellent, but if you can do some weight-bearing exercises, it's all the better for your bones. And then in certain cases, we may have to order some tests, what's called a bone mineral density. By doing bone mineral densities, women go through these all the time, we have to start using this for men, because if we find that a man is osteoporotic, well then we can intervene with a drug, like these drugs. We have a drug called Xgeva. We have bisphosphonates like Fosamax, Iridia, Zometa. All these drugs can help prevent bone loss. So it's an important thing that we as urologists that use hormonal therapy have to be aware of. But more importantly, when cancer spreads to the bone, a prostate cancer patient has two problems. One is the cancer itself that affects the bone, but two, our treatments can affect the bone. So there's two reasons why a patient can have trouble. And in this setting, there's no discussing, we have to intervene. Some of the things that can go wrong, a patient can have a fracture. We can have what's called spinal cord compression. This is unfortunately a very devastating complication where the patient becomes paralyzed because the cancer has spread beyond the bone. Sometimes they have so much pain we have to intervene with radiation treatment, and sometimes we have to even operate on the bone. All this because of the cancer that has metastasized to the spine or the bone. Well, these are the rates. So men who have advanced prostate cancer, a third of them need some form of radiation. A quarter of them, unfortunately, suffer a fracture. Fortunately, not many, but still, it's not insignificant. 8% develop that catastrophic spinal cord compression. We don't want these. We need to decrease these. And we can. There are drugs now that are available that can do this. And the newest drug that can do this is called Xgeva. This is now approved and available. This is a drug given subcutaneous, whereas previous drugs before had to be given intravenously. We can now give a drug that's potent subcutaneously under the skin once a month, and this has been shown to decrease all of those risks significantly. And not only does it decrease it from occurring, if it does occur, it delays it from occurring. So vitamin D, calcium, healthy lifestyle, stop smoking, walk, do some weight-bearing exercises, and ask your doctor about one of these treatments that can help reduce bone complications. Finally, I think the message is positive. We have many new developments, as I've shown you, for prostate cancer, especially for men who perhaps the local treatment was not successful. There are many options and many available treatments that can maintain quality of life and extend life. But none of this would be possible without research, so I thought I would just talk to you a little bit about what Procure is doing in terms of research. As Malvina mentioned, please visit our website to learn more. Our job is to promote awareness and public education like we're doing tonight, but also is to promote research. And this is where the whole field of medicine is going, not just prostate cancer. The idea that we can take each individual person in this room, take a blood test, take a piece of the cancer, and fingerprint that cancer to determine, you know what, this person, it's better to give this drug. This person, this drug's not going to work, let's give this drug. To be able to do that, this is what we want to do, called personalized cancer treatment. Molecular fingerprinting. You can actually fingerprint cancers. So, but to do that, you need a few things. You need scientists that understand how to study these things. You need obviously laboratories that can do this. You definitely need money and funding. But when you have all three, there's still one piece missing. And that's the human samples. We need material from men who've gone through the treatments so we can test, we can do the fingerprinting, we can determine what molecular fingerprint or signature correlates with what outcome. And that's where Procure decided to invest its energies. And so we're building, we're almost finished building. Now we're into the follow-up phase of what's called a biobank. This is a provincial project done across the 4 major teaching hospitals in the province, with a head office all run by our charitable organization, Procure. And the idea is to collect samples on a repeated basis from men who have suffered from prostate cancer across the province. Quebec is a unique place where we can do this. We've been actually very successful in collecting, and to date, almost 2,000 men. I think some of you in this room have participated in this project. It's a great project which will provide the samples needed to get to that molecular fingerprinting. So on that note, I'd like to end my presentation, and I think we'll take questions afterwards. Thank you for your attention.
Thank you so much, Armin. Should say that Armin was the brainchild behind the biological bank that he introduced to you just a couple of minutes ago. Thank you for sharing the new developments. Lots of hope and a lot more work to be done, clearly.